Yeah, thank you very much. So, actually, I noticed on the program it said retinal telangiectasias. Right, we can talk a little bit about quotes at the end if we've got time. But what's new and what's hot is macular telangiectasias. So, Gas, obviously, published the first descriptions and called it actually juxtafoveal idiopathic retinal telangiectasia, and divided it into two groups and then subdivided it and then found out some other case reports. In actual fact, practically, we divide macular telangiectasias into two main groups, type 1s and type 2s. They're very different diseases pathophysiologically. I wouldn't worry about the 2B, 3A, 3B. These are just isolated case reports. They haven't been really replicated by anyone, so we'll concentrate on the first two. So in terms of its incidence, we often quote the Bivendam eye study, the Melbourne collaborative cohort study. This is historical data. They're based on fundus photography. You can't really diagnose MacTel on a color photograph. So on the one hand, the Bivendam probably overestimated the incidence of MacTel too. The Melbourne study underestimated it. No one really knows what the true incidence of MacTel is. So we'll first talk about MacTel 1. It's typically a unilateral condition. It's probably part of the spectrum of Coats disease, and it involves an exudative telangiectasia with intraretinal edema, and you often see how it exudates. So this is an OCT of a patient with unilateral involvement. We see cystic macular edema, telangiectasia, exudation. This is the autofluorescence. Importantly, with MacTel 1, the autofluorescence signal is normal. The macular pigment is intact. You may get some high signal where you have the cystic macular edema, but you will see that in any cystic macular edema. Angiography, you see the telangiectasia. OCTA will show you deep plexus dropouts. Obviously, you have the late leakage. On the more wide field images, and if you go really far out, you might find subclinical peripheral vascular changes, which supports the notion that type 1 macular telangiectasia is part of the Coats spectrum. Now, how would you manage it? Well, it behaves very similar to a branch vein occlusion, a diabetic macular edema. So first-line treatment will be with anti-VEGF agents. There have been some reports with macular laser, which also works. It's a reasonably straightforward disease to manage, and the outcomes are reasonably good. Now, MacTel 2 is a very different disease. It has a later onset, it's bilateral, but it can be asymmetric. There's no gender bias. It's often associated with diabetes and arterial hypertension, and there is a genetic predisposition. You will find familial clustering, and there's a higher prevalence in monozygotic twins. So, fundoscopically, with early MacTel 2, you might not be able to see anything. There's published kind of progression and staging where you meant to see loss of retinal transparency and graying, blunted retinal venues, and then you start getting lamellar holes, cysts, pigment hyperplasia, and then some patients end up with CNV. There's no exudation unless there's CNV. OCT and fundus autofluorescence imaging has really revolutionized the way we recognize and diagnose this condition. So the earliest signs, and really you might not be able to see it on someone who only has this, but you will often, if you look out for it in a fellow eye, you often see it. You get thinning of the temporal foveal pit. And on autofluorescence, you may see temporal loss of pigment, so you get increased autofluorescence masking. And all these precede vascular changes. In later stages, you start seeing tissue loss. It looks like a cystic macular edema, but it isn't. It's true tissue loss. You then get photoreception loss, atrophy, and it can progress to a full-thickness macular hole. These macular holes are very different to tractional macular holes that we often see. and autofluorescence, we see progressive pigment loss from temporal to nasal. You can then get the proliferative stage, where we get CNV, and the hypothesis is that this is a primary neurodegenerative condition with secondary vascular changes. So this is OCT of a patient who has symptoms in the left eye. We see what looks like a cyst, and we see some photoreceptor layer atrophy. But on the fellow eye, you will see, you will see that temporal fovea the contour changes, and you do get sort of slight depression of the retinal tissue. On SLO imaging, the left side is a type of red-free image with blue reflectance. On the right-hand side is autofluorescence. So the principle of this imaging is that on the blue fluorescence, it's just a photograph with a monochromatic blue light which is reflected by the retinal surface. On the other side, you put your fluorescent filter, so you stimulate with the blue lights, and you try and pick up any lights of a longer wavelength, which represents the autofluorescence from the lipofuscin. So on the one side, autofluorescence should be a uniform gray, it should be a uniform signal, apart from the fovea where you get absorption from the macular pigment. But as you can see in this case, you have loss of macular pigment and increase autofluorescence temporarily. And that corresponds to an increased area of reflectivity on the blue reflectance, which is the loss of retinal transparency that people have described. This is from a publication which is a slightly different type of imaging, but illustrates the loss of macular pigment from the temporal to nasal as the MacTel progresses. As you can see, the pigment imaging and OCT are displayed longitudinally, and you can see as the MacTel progresses to atrophy, we have almost complete loss of macular pigment. Now, in terms of management, this is a very interesting story on the importance of practicing evidence-based medicine. So, with the advent of anti-VEGF treatments in the noughties, there have been case reports of ranibizumab inducing regression of cysts. So, sounds like a good idea. Let's start doing it. So, there was a prospective randomized controlled trial of monthly ranibizumab in MacTel 2. And the results of that study at 1 year, they found that in the treatment group, there was regression of the cysts, but the visions just stayed the same. So they stopped the trial. Interestingly, there were no more injections after year 1. But at year 5, the treatment group had much more atrophy and a worse visual outcome compared to the control group. So we must not use anti-VEGF agents in the non-proliferative stage of MacTel 2. Although these changes may look like cysts, they're not cysts, it's atrophy, and anti-VEGF agents seem to make that worse. Now, if there is CNV, then we should treat with anti-VEGF, but perhaps this is not evidence-based, but we should be cautious and try and treat as little as possible because of these long-term effects of anti-VEGF agents. And just maybe we should move to a PRing dosing as soon as possible rather than a treat and extend type protocol. Now, differential diagnosis with MacTel 1, it has fewer discriminating features compared to other exudative capillary inner retinal diseases. So, you could see a patient who may have had an old, small, tiny macular branch retinal vein occlusion. It can look like MacTel, but if you do angiography, you may find a more widespread vascular change compared to MacTel 1. Well, in a diabetic with established diabetic retinopathy, it can be pretty much impossible to differentiate MacTel 1 from a diabetic macular edema, but, practically, the management is the same, so you just have to go in and treat it. Radiation retinopathy can look like MacTel 1, but there should be a history of radiotherapy, and on angiography, the involved area should be much wider. Also, you often see cotton wool spots, and retinal neovascularization with radiation retinopathy, something that you shouldn't see with MacTel 1. With MacTel 2, really with the advent of fundus autofluorescence, and now that we have all these new OCT markers, it has, if you meet the diagnostic criteria, they should have a very high sensitivity and specificity. But with very early MacTel 2, you need a high index for suspicion and to look out and recognize these signs. Thank you very much. Any questions?
Any questions from the audience?
I have a question. Petros, many congrats on an excellent delivered talk. I would like to ask you about a patient, if you have a patient with MacTel, and there is
one or two.
Type A,
Yeah.
confirmation of the disease with OCT and angiogram, no CNV, but it is on the stage of cavitation formation, and the patient is losing visual acuity.
So
would you go on with treatment even if he had no CMV, but it's in the cavitation stage and the patient is losing the visual acuity?
So we're talking about MacTel 1 or MacTel 2?
Sorry, MacTel 2.
No, because the studies have shown that in the long term, these patients would do really badly with anti-VEGF agents.
What would you do in this patient? Would you give him? We usually give him steroids also a few years ago.
The problem is that there's no evidence base for steroid treatment. So you just have. We have to accept that for some conditions, we have no effective treatment, and the number one rule is not to make the situation worse. So you'll try and reassure the patients as much as you can. You should explain that right now we have no other way of managing this disease. They should stop perhaps smoking. I don't know if giving them some vitamins will do any help. Actually, there's no evidence base for that either. But you just have to watch them for CNV. You give them an Amsler grid, and the most important thing is not to make matters worse. And yes, you're right. I mean, with anti-VEGF, they look better on OCT, but they will get much worse. So that's the one thing you must not do.
How confident is the correlation between anti-VEGF and the atrophy in this group? I mean, it was somehow in the primary endpoints of is a meta-analysis? Is it something that you can confidently use as a criterion for your treatment?
Well, this is actually a publication from Frank Holt's group in Bonn. So Frank Holt's group was part of the original MacTel trial, and they just collected all the data at 5 years and they published it. So you're right, it's not a primary endpoint of the trial. The trial ended at year 1, but in the absence of any benefit at year 1, and with the evidence that things are much worse at year 5, I can't see any justification in giving this treatment. Unless there's CNV. If there's CNV, then you should treat, but try and minimize the injection of and the frequency of injections.
One last question from Paris.
I recently came across a new entity which extends a bit the broad of type 1 telangiectasia, which is this pepper, very vascular, aneurysm, vascular abnormality.
Okay.
And essentially, it refers to an entity that you can see an isolated large aneurysm around the fovea. And this is something, I think that this was probably underdiagnosed, because occasionally we do see these things.
You're right.
And we don't know what it is. It is quite different than the type A telangiectasia, because type A has more telangiectatic vessels, and this is just an isolated aneurysm. But I think it's good to know, and it's good to broaden the spectrum of
Yes, I mean, MacTel 1, Coats disease, there's a huge spectrum of disease, and we know that anti-VEGF agents work really well for this. Just to make a little note, I know that the topic title was Retinal Telangiectasia. Maybe we should talk a little bit about Coats. We've got time, haven't we? Or no? We haven't, actually. No worries. Okay, great. Thank you.